Great. Thank you so much, everyone, for being here this evening. I know it's stressful times, and this is your precious time. What we're going to do is talk about some of our global surge, COVID surge work. Much of it has been published that we're going to talk about this evening, but there is more to come. And I'm also going to do multidisciplinary rounds in May to cover off this topic more completely. So we're going to cover two topics today, and then we're going to cover an expanded range of topics in May for multidisciplinary rounds. So today what we're going to talk about is COVID-19 and surgery. We're going to talk about timing of elective surgery post-recovery from SARS-CoV-2. And we're also going to talk about the role of vaccines. Now, of course, this is sort of a triple aim here this evening, but I think quite easy to do in the next 40 minutes or so. And then after that, I'm really happy to take questions and to have a bit of discussion as well. So the three objectives that we'll cover today are: does perioperative SARS-CoV-2 increase mortality? And when is it safe to provide elective surgery in SARS-CoV-2 survivors? And then we'll also talk about what is the role of preoperative vaccinations. So this data is, or both of three of these objectives that we're going to cover today are coming from the Global Surge COVID Surge Collaborative. Now, as you know, I have been involved with the Global Surge Collaborative now for a few years and have had the great pleasure of working with many countries worldwide through this Global Surge and COVID Surge Collaborative. And this has really culminated in now almost, over 120 countries gathering together throughout the COVID pandemic to put together, I guess now, the largest prospective cohort study ever done in the world of surgery. So the data we're going to talk about today comes from, yes, our largest study from the COVID Surge Collaborative, but also from some of our earlier studies that we did together early in the pandemic. And so we've done 3 in total now. And I really want to just give credit to what I'm going to present here tonight to the Global Surge COVID Surge Collaborative. And it's headquartered in University of Birmingham. They've been working hard throughout this pandemic and prior as well, just to coordinate this whole thing. So kudos to them. I also want to thank our local collaborators here. There were quite a few of you. So thanks to all of you who offered to collaborate on this COVID Surge Collaborative. I was able to accommodate everyone who offered to help for our studies, especially the one in October, November, the biggest one so far. So you can see here highlighted in blue a number of our anesthesia colleagues here, and then in white, our surgical colleagues. I also want to just give kudos to our coordinators at Medici, Jess and Amy. And we often forget to thank the Western REB. So ethics really came forward and allowed us to have an evaluation as well as local approval within some short time frames, as well as our information support team here at the hospital. So let's start off with a little bit of the background. So first of all, what we did as the pandemic opened and spread across the world, one of the first things we did with the COVID Surge Collaborative was to take a look at the rate of cancellations of elective surgeries. And we found, when we took a look at what we knew at the time, and this was during the first peak of the pandemic in March through May, we gathered as much data as we could by country level and then extrapolated to the rest of the world. And we estimated that at that time, during the first peak pandemic, there was already 28.4 million surgeries canceled, and at least 2 million of those being cancer surgeries. And we figured that over 70% of all elective surgeries were canceled during that time. Now, fast forward to today, we're back in it deep. And I looked at the Ontario numbers just earlier this weekend, and our estimates for Canada and then Ontario at this particular time were right on par. And in fact, now in Ontario, we're between 200,000 and 300,000 surgeries alone canceled. So then what we also did was early in the pandemic during the first wave, March through May, we also took a look at of all the surgical patients coming through around the world, of those patients undergoing surgery who were subsequently diagnosed with COVID or with SARS-CoV-2 around the time of surgery. So this was either in the pre-op setting, they were diagnosed and then underwent surgery, or in the post-op period, if they were diagnosed anywhere up to 30 days with SARS-CoV-2. What we wanted to know is if their outcomes are worse. And we had reason to suspect that their outcomes might be worse, and our suspicions were confirmed. So when we took a look at a cohort of our first 1,100 SARS-CoV-2 positive patients undergoing surgery, and this was typically urgent surgery because there weren't a lot of elective surgeries at that time during the first peak, we found that the mortality rate was excessively increased. So we found that 24% of patients died postoperatively if they were diagnosed with SARS-CoV-2 around the time of that surgery, up to 30 days. We also found a high rate of postoperative pulmonary complications. So 51% of patients had a postoperative pulmonary complication. That's pneumonia, ARDS, or unexpected post-op ventilation. And it seemed that the majority of the people who died also had had a pulmonary complication. Now, we also found that, of course, there were risk factors that were predictive for an excess risk of mortality: male sex, age over 70, cancer diagnosis, major surgery, and emergency surgery were among those risk factors. Now, we published that in the spring in the Lancet. And of course, the feedback was, yes, that's very interesting and very useful. But of course, it's just a cohort of SARS-CoV positive patients. Wouldn't it be great to have a comparator group of contemporaneous patients who underwent surgery also during the pandemic, but who did not have SARS-CoV-2 diagnosed, so that we could have a risk-adjusted, age-adjusted cohort to take a look at? So that's actually what we did. We went ahead and revamped and recreated a methodology to now go forward and do the largest prospective cohort of surgical outcomes during the pandemic. And this is called the COVID Surge Global Surge Week study. Sometimes I'll just call it the Surge Week study. And it involved almost 120 patients, over 1,600 collaborators, and collected data in this single study alone on over 142,000 surgical patients. And also followed them up for 30 days to evaluate risk of mortality in those with SARS-CoV-2 diagnosis and those without SARS-CoV-2 diagnosis. And this is across all types of surgery, all ages, whether elective or emergency, during October of this past year. So the idea was that all the centers who are volunteering to commit to collect data would identify which types of surgeries they will collect data for. And once they've committed to a week, at least 1 week in October, but they could collect up to 4 weeks of data. Once they've committed to a week, then they need to collect all the surgeries of that particular type. And some hospitals, such as ours in London here, collected data on all types of surgeries throughout that particular cohort period in October. And so with the Global Surge COVID Surge Week, the idea was that, yes, we would involve all hospitals, any hospital around the world, any surgical specialty, hopefully all of them, all ages, day case, inpatient, outpatient, elective, emergent. And our first goal here was actually to take a look at 30-day mortality, and to do so comparatively for those who did not have a COVID diagnosis or had no SARS-CoV-2 diagnosed. Okay, so that should just be routine postoperative mortality rates. But of course, during a pandemic, so maybe not actually quite normal. And then compare that with patients who had a SARS-CoV-2 diagnosis around the time of surgery. But we wanted to stratify that by the time between the diagnosis of surgery the time between the diagnosis of SARS-CoV-2 and the time of their surgery. So we really wanted to see whether or not the time that has elapsed since their diagnosis of SARS-CoV-2 before they have surgery, whether that would make a difference in terms of their postoperative mortality risk. So these are the papers we're going to focus on today then. So what I just gave you was a little bit of the background on our first Lancet paper, as well as our first cancellations paper. And now I just want to focus in on the parts of the Surge Week study in which we actually took a look at two separate questions here. So what is the safe timing of return to surgery after somebody has had COVID in the past? So we'll talk about that. That was published in Anesthesia just about a month ago. And then also want to take a look at the role of vaccinations and whether or not that as an intervention could then reduce the risk of mortality in our preoperative elective surgical population. I'm also showing you here an editorial that Dominda Wijesundara and Kataru actually published just this weekend, and it also was really helpful, taking a look at the timing of return to surgery post SARS-CoV-2 diagnosis. So there's two parts to this. The first part, we're actually going to talk about the role of preoperative vaccination. So the idea here is that if our elective patients, the patients that we're scheduling for surgery, if they are at high risk, both of getting SARS-CoV-2 diagnosis, either because of their exposure to the hospital or because of their condition, their surgical condition, and then if they are at high risk of contracting COVID, they are also at risk of poor postoperative outcomes. So as I showed you, excess risk of mortality and also excess risk of postoperative pulmonary complications. So if that's a given, then could it be that if we could actually prioritize vaccines to have our patients get it preoperatively, would that impact on the risk of SARS-CoV diagnosis and SARS-CoV mortality in the postoperative setting? And would it be worth it? So we know that vaccine supplies are limited. And, because the supply is limited, we have to be very careful in whom we prioritize into that priority list. So the question here is, should our elective surgical patients be prioritized? And if so, which ones? So let's take a look at what we did. So what we did here was we took our Global Surge COVID Surge Week data, and again, global representation there from most countries of the world, actually. And then we took the part of that data that met the following criteria. So we were looking only at elective surgery in this particular case, and we were only looking at those who had information post-operatively in terms of a COVID diagnosis. So our primary outcome here was taking a look at, we were trying to estimate the number needed to vaccinate in order to prevent one COVID-19 related death over 1 year. So the number needed to vaccinate was our primary outcome. And we estimated this NNV based stratified by surgery type. So we took a look at cancer versus non-cancer surgery, and we also stratified by age, of course, because age is so closely related to the risk of postoperative mortality rates. Then we modeled, based on data from this Surge Week study, the effect of vaccines. So this, because in our COVID Surge, Global Surge Week study, we didn't actually have patients vaccinated at the time. So we couldn't look at the impact of vaccine in our actual clinical data because vaccines were not available last October. So what we had to do was take the risk of mortality in patients who got COVID postoperatively in our study versus those who did not get COVID postoperatively in our study, and compare that risk of death with the general population and overlay the impact of preoperative vaccination on that risk of death. And then compare the number needed to vaccinate to prevent one death at 1 year in the surgical population compared with the general population. So a couple of clarifications here in terms of the methodology. So we took a look at, of course, for a model like this, what we need to know is the SARS-CoV-2 incidence in the community. And we also need to understand the SARS-CoV-2 incidence in the surgical population across every type of surgical procedure and across all age groups. And so our Surge Week study gave us that, and we used the incidence of postoperative SARS-CoV-2 diagnosis for the first 30 days from our study. And then we considered that after 30 days, we'll put that incidence of SARS-CoV-2 diagnosis back to the regular population rate thereafter, which is perhaps a bit of a conservative estimate, but we thought that's best to be conservative. And then we also needed to estimate or calculate adjusted case fatality rates. And we did that for the first 30 days postoperatively from our large Surge Week study, age stratified, procedure stratified. And we took a look at those mortality rates again for those who did versus did not get COVID perioperatively. And then we considered the case fatality rates thereafter, so the 31 days to a year postoperatively to go revert back to what it would be in the general population. So again, we're just really applying the real data from our study in the first 30 days, and then thereafter assuming population-based levels to be conservative. And so our postoperative SARS-CoV-2 event rate. So this is interesting because it's elective surgery only. So we found that, again, stratified by age and stratified by non-cancer versus cancer surgery, we found that the incidence of SARS-CoV-2 diagnosis postoperatively ranged from about 0.68% up to about 1.6% across the age strata, and it was higher in cancer patients than non-cancer patients. But because this is only elective surgical patients, it's a little bit lower than in our overall study population, which I'll tell you about later. So it's an incidence rate that we cannot ignore, that's for sure. But it is overall just hovering around 1% or so. So what did we find? Well, interesting, right? So for postoperative SARS-CoV-2 mortality, now remember, this is big new data, which is in agreement with our initial Lancet paper, but now we have the comparative data, contemporaneous comparative data. So this is stratified again by age and again stratified by cancer versus non-cancer surgery. So in the top bar here, we have age 70, greater than or equal to 70 years, and the next strata is 50 to 69 years, and the next strata is age under 50. And here what we found was that the mortality rate for patients diagnosed with SARS-CoV-2 was significantly higher than patients who were not diagnosed with SARS-CoV-2 postoperatively. Okay, and you can see the absolute magnitude of difference along the metric along the bottom here, along the bar. So these are adjusted 30-day postoperative mortality rates, but you can see the absolute difference is quite large, and largest in patients undergoing cancer surgery and of older age cohort. You can see that the difference in postoperative mortality rates existed for each age strata, even in the youngest cohort, but you can see the absolute difference is quite low in a younger age group, and especially those without cancer surgery. So then what did we find for our primary outcome of number needed to vaccinate to save one life over 1 year? Well, we found that regardless of which age strata you look at, it is always advantageous to provide preoperative vaccination and compared to the general population. So for preoperative vaccination in the elective surgical population, you will always save a life sooner with the vaccine than you would in the analogous general population of the same age strata. And this is very interesting because it helps us now to think about how to prioritize the vaccines. So all things equal within the same age strata, we know that elective surgery should be prioritized. So the number needed to vaccinate is actually given along the right column here. So you can see that in age greater than or equal to 70 years undergoing elective surgery with cancer, it takes just 351 patients to be vaccinated in order to save one life within a year. In that same age cohort, without cancer undergoing elective surgery is about 733, whereas in the general population is about 1840 patients in order to be able to save a life with the same vaccine. Now, in age 50 to 69 years, you can see that the same pattern exists, but the number needed to vaccinate is a bit higher. So elective surgery in age 50 to 69 undergoing elective cancer surgery is about 559 patients needed to be vaccinated in order to save a life at a year, whereas non-cancer elective surgery in that age cohort is about 1,600 to save a life. But that's quite a lot lower than the general population in that same age cohort. Now you can say the same pattern exists for age under 50 years of age, but now you're getting into a situation where yes, on average, you will save a life sooner vaccinating an elective surgical patient under age 50 undergoing cancer surgery, for example. You'll save a life, within 4,000 vaccinations given. But now you're starting to compete with the numbers in the higher age groups. And so it's just a little bit harder for us to say necessarily that as a prioritization group, that this younger age group should be prioritized above the ages above in terms of versus the general population. So if we also just want to think about generalizability, because of course, all of these number needed to vaccinate estimates are entirely dependent on just what is the community incidence of SARS-CoV-2. So if of course, because that is relevant, we calculated here the generalizability of these number needed to vaccinate values for the general population in blue, non-cancer surgery in yellow, and cancer surgery in red. And you can see that of all three age cohorts or age strata that we took a look at, regardless of the community SARS-CoV-2 incidence, it is always advantageous for the analogous cohort of age to be vaccinating elective cancer surgical patients to be prioritizing vaccination for them, as it is for non-cancer surgical patients. So then this is just another way to look at it in an infographic. If we collect all the elective inpatient cancer surgeries, the number needed to vaccinate to save one life in a year is given along the side here for each of the three age cohorts. And the relative volume just given in terms of the relative number of people here shown in the infographic. So you can see that in general, of course, age 50 and above, undergoing elective cancer surgery, but even elective non-cancer surgery, the number needed to vaccinate is quite a bit lower than the general population. And this suggests that we should be prioritizing vaccinations for that particular group. Now, we also estimated across the globe, if we could today, given the incidence of community transmission across the globe, across the different countries, if we could, at the time of writing this manuscript, have had priority access to vaccinations for our elective surgical patients, we could save an extra 58,687 lives this year. So we're proposing that our governments really should be prioritizing preoperative vaccination of surgical patients. So that leads us into part B. So this is now about timing of surgery in patients who have previously had SARS-CoV-2 diagnosed. And this is also very interesting data coming from our large Surge Week study. So I'm just going to jump back to the background in a second here. So this is now the rationale for why we also went ahead and did this big study. As I mentioned in our Lancet paper of our first cohort of 1,128 patients, all of them SARS-CoV-2 positive undergoing surgery. We found an overall mortality rate of 23.8%. And it was interesting because if you take a look at those who were diagnosed preoperatively with SARS-CoV-2 versus those who were diagnosed postoperatively with SARS-CoV-2, which would be a mix of those who were undergoing surgery perhaps during the incubation period, or who may have actually contracted SARS-CoV-2 nosocomially. But it's interesting because in both of those cohorts, the mortality rate was quite similar, right? It was 21.3% in those preoperatively diagnosed versus 25.6% in those postoperatively diagnosed. What we couldn't do, given that this early paper, this early Lancet paper, was simply a cohort of SARS-CoV positive patients undergoing surgery. Again, we didn't have that comparative group. And we also didn't have finely parsed data in terms of timing of the diagnosis. In order to be able to compare cohorts across time strata since their diagnosis, between diagnosis and surgery, in order to be able to understand whether or not the risk of mortality changes after time, after time has passed post-diagnosis. Plus, we also felt we really needed to go big in order to be able to take a look at whether or not there are differences by age strata, risk strata, emergency versus elective, major versus minor surgery, inpatient versus out, and by type of surgery as well, and across the ages. So we decided to do a very large cohort study, as I mentioned. So this is the same international cohort study. And here now we're taking a look at whether or not the risk of mortality as our primary outcome, a risk-adjusted mortality, age-adjusted mortality rates at 30 days are different according to the time post SARS-CoV-2 diagnosis to surgery. We also took a look at, of course, 30-day pulmonary complications and other outcomes as well, which I will tell you about in May at the Grand Rounds. So again, same cohort, same countries involved, but you can see in this previous slide here that we actually calculated adjusted mortality rates, adjusted for age, sex, ASA at baseline, RCRI, respiratory comorbidities, grade of surgery, urgency of surgery, country income, timing of surgery following SARS-CoV-2 diagnosis. So that's our time strata. So at baseline, it's interesting because now we, in this study, have both elective and emergency surgery patients included, over 140,000 of them. And this larger cohort now, we find that there is a 2.2% incidence of perioperative SARS-CoV-2 diagnosis. And the time from SARS-CoV-2 diagnosis to surgery, so in those who were diagnosed with SARS-CoV-2, of them, about 38% were underwent surgery 7+ weeks after their diagnosis, whereas other 36% underwent surgery within the first 2 weeks of their diagnosis, and about 15% underwent surgery within 3 to 4 weeks of their diagnosis, and 10% within 5 to 6 weeks of their diagnosis of SARS-CoV-2. And also, just giving you the baseline characteristics here, of those that had the SARS-CoV-2 diagnosis after surgery, we also took a look at and stratified by whether or not the patients had ongoing symptoms. 13.7% of them did at the time of surgery, or whether or not their symptoms had resolved at the time of surgery, and that was about 42% that had resolved symptoms. And then we also took a look at those who were asymptomatic, so they never had symptoms, but were diagnosed with SARS-CoV-2 positive by virtue of preoperative screening, or by virtue of having been tested because of family members or other exposure. So what did we find? Well, we found that the adjusted 30-day mortality, and these are actual mortality rates given along the adjusted mortality rates given along the side here. So we found that for all patients, the overall baseline risk of mortality postoperatively in those who did not have a SARS-CoV-2 diagnosis was about 1.5% risk of mortality. But those who had a SARS-CoV-2 diagnosis, that's the remainder of the rows here. And each of those cohorts had an increased risk of postoperative mortality, whether at 0 to 2 weeks or 3 to 4 weeks or 5 to 6 weeks post-diagnosis when their surgery occurred. It was only after 7 weeks that the risk of postoperative mortality returned back to about 1.5%. So it's interesting because that's all patients. So that's whether elective or emergency, et cetera. So here we're just taking a look in the bottom at the elective surgery patients alone. And here you can see that, of course, elective, so without the emergency surgery patients included, now we have a lower risk of postoperative mortality of 0.62% in the non-SARS-CoV-2 patient population undergoing surgery. But even in the elective surgical patients, similar patterns. So if they had a SARS-CoV-2 diagnosis and underwent surgery within 0 to 2 weeks of that diagnosis, they had a 3.1% risk of mortality and a 2.3% risk if it was 3 to 4 weeks undergoing surgery post-diagnosis, and about 2.4% if undergoing surgery at 5 to 6 weeks post-diagnosis. And again, after 7 weeks, that risk of postoperative mortality went back down to baseline of about 0.6%, same as those who never had a diagnosis of SARS-CoV-2. So it's interesting because if we just take a look at general patterns here, whether or not it's all patients in the study or just the elective patients in the bottom panel, you can see that the pattern is the same, whereby those who have never had a COVID diagnosis and those who have but waited at least 7 weeks before their surgery occurred, their postoperative mortality rates are the same. It is those who undergo surgery post-SARS-CoV-2 diagnosis within 0 to 6 weeks of that diagnosis that have an excess risk of mortality. And this is another way of looking at it. Now we've flipped, and this is actually a graph that's that Domindo Wijesundara published in his editorial this weekend. And so what he did was he took those adjusted mortality risks, which is the actual percent, so you can think of these as absolute risks. And he took a look at, okay, let's take a look at those who are undergoing emergency surgery across these time strata. Emergency surgery in the red bar, and in the dotted red bar, emergency surgery without SARS-CoV-2. So at the top here, we have emergency surgery with SARS-CoV-2, excess risk all the way up to 5 to 6 weeks post SARS-CoV-2 diagnosis, falling back to baseline if waiting to undergo surgery after SARS-CoV-2 diagnosis at least 7 weeks. Okay, now for the elective surgical patient population, the same pattern applies. It's just that the absolute differences are smaller. So SARS-CoV-2 positive patients undergoing elective surgery in green at 0 to 2, 3 to 4, and 5 to 6 weeks post-diagnosis have an excess risk. That risk only goes back to baseline, same as those without ever having a SARS-CoV-2 diagnosis, only after waiting 7 weeks post-diagnosis to undergo surgery. So a number of subgroup analyses were done by age, by differing age strata. So here, all ages up to 69 years, and then over 70, greater than or equal to 70, same pattern applies. Same pattern applies for minor versus major surgery. Also for ASA grades 1 and 2 patients separated from grades 3 to 5 patients. And I just showed you the elective versus emergency surgery patients. So you can see same pattern applies. There is a separation in terms of the absolute difference in risk of mortality between those who undergo surgery around the time of diagnosis of SARS-CoV-2. And that falls back to baseline after greater than or equal to 7 weeks. So then we also took a look at, and this is interesting, so we took a look at, as promised, whether or not the symptomatology or the degree of COVID symptoms experienced by the patients made a difference in terms of excess risk of mortality. And so you'll see at the top here, we have of all the patients who were diagnosed with SARS-CoV-2 and underwent surgery, stratified by time, but who never had symptoms. Was there a difference in postoperative mortality rates? And the answer is yes, there was. There was an excess risk at 0 to 2, 3 to 4, 5 to 6 weeks post-diagnosis, going back to base after, or reducing after greater than or equal to 7 weeks. Same pattern, but just lesser absolute difference. But you can see that those who had resolved symptoms had an excess risk of mortality that in absolute terms was greater at 0 to 2, 3 to 4, 5 to 6 weeks, going back down at greater than or equal to 7. But those with ongoing symptoms had an excess risk, of course, that was greater, and the absolute risk was really quite large, greater than 14% in those with ongoing surgery, symptoms, undergoing surgery within 0 to 2 weeks of their diagnosis, but staying so high, almost 14% in even 3 to 4 weeks post-diagnosis with ongoing symptoms. And then still really high, about 13% at 5 to 6 weeks post-diagnosis. And also high even at greater than or equal to 7 weeks post-diagnosis, though quite a lot lower. So again, a graph from Dr. Vijay Sundara. And here we see that, again, we have adjusted mortality risk on the y-axis now, and these time strata along the x-axis. And it just shows you, again, those with persistent symptoms have an absolute risk of mortality postoperatively that is very high. And that continues until after 6 weeks. And that risk is lesser in those with resolved symptoms, but still elevated. And those with asymptomatic disease, their risk is on absolute terms lower, but still excessive compared to baseline risk at all these time strata. So we also took a look at pulmonary complications, and I just have one slide on this because all of the messages are the same. Excess risk of pulmonary complications, that's ARDS, pneumonia, or unexpected postoperative mechanical ventilation. And it's uncanny just how similar these patterns are also for other outcomes that we looked at. So just my last few slides, and then we have some time for discussion. So strengths and limitations, it's always really important to reflect on these when we do studies like this. So this was, in terms of the strengths, so this was really a large study, and I guess the largest ever done in the world of surgery and anesthesia. Over 142,000 patient data collected. And kudos to everyone who was involved. I mean, what a feat, right, during a pandemic. It also, we really were very careful to have high data completeness for all the patients. And in terms of our hospital involvement, we collected about 700 patients over the course of 1 to 2 weeks, depending on which type of surgery. But we did collect all surgeries for at least 1 week. No missing data points. We also have a lot of interesting generalizability that we can also assess. Because we included low, middle, and high income countries, we can take a look at low and middle and high income countries separately, and also take a look at the role of Human Development Index and Country Index on the effect sizes. And as I mentioned, we did a adjusted analyses, including that in the adjustment. And it also agrees with previous cohorts on this question of timing of return to or timing of surgery post SARS-CoV-2 diagnosis. So there's been two previous cohorts. One of them was our previous COVID surge study that we published in the Lancet with 1,128 patients. We were able to take a look a little bit at the impact of time. It wasn't as granular, but we did find that those who waited a longer time post SARS-CoV-2 diagnosis for the surgery did better in terms of risk of mortality than those who were earlier post-diagnosis. So we had some preliminary inkling from that, and then there's been another recent one from France, a national study that took a look at return to surgery post-diagnosis, found very similar results, but with much smaller numbers. Now, in terms of, so there's a lot of strengths, I think, in this study. Now, we also have to be reminded that this is a cohort study. So for two questions that we were looking to answer today, right, whether or not mortality is increased across these different time strata post-diagnosis. And of course, the question is always, is there residual confounders that we have to be aware of and that we might not have been able to adjust for? And do we have the risk of misclassification bias? So for example, if patients were asymptomatic and came in for surgery and may not have been preoperatively given a a nasal swab or a preoperative screen for SARS-CoV-2 of any sort, besides the clinical screen. It's possible that those who were asymptomatic might not have been classified as SARS-CoV-2 positive. Meanwhile, we know there is a significant asymptomatic population, and they may have come through for surgery and ended up in our classified in our study as a non-SARS-CoV-2 positive patient. And if they were in the non-COVID patient population in our study, that would have actually resulted in a more conservative estimate. And we already found huge effect sizes. So if that misclassification bias happened, it would actually, if we could correct for it, make our numbers even more stellar or bigger differences. We weren't able to answer the question of how long after 7 weeks should you wait if the patient still has symptoms, because our data doesn't go that far. We also weren't able to understand or have enough granularity to understand which symptoms portend the worst surgical risk. And also, of course, all the questions about vaccines. So which vaccine and the timing of vaccine preoperatively. Of course, we can't really speak to that except for what we know about vaccines more generally. And we can discuss that in the discussion if you wish. So take-home messages, here they are. So patients with perioperative SARS-CoV-2 infection are at risk, increased risk of death and pulmonary complications. And governments should prioritize vaccines for elective surgical patients, especially for cancer surgery, and especially for patients probably 50 and above undergoing elective surgery. And lastly, in patients with prior SARS-CoV-2 infection, when possible, elective surgery should be delayed. So surgery should be delayed if possible 7 weeks after the diagnosis of SARS-CoV-2. Okay, if possible, and we'll come back to that if possible, and greater than 7 weeks if symptoms remain. But of course, this requires all sorts of clinical knowledge and careful weighing of the trade-offs of delaying further that elective surgery versus exposing the patient who has had SARS-CoV-2 to the double insult of surgery plus SARS-CoV-2. And I hope that the numbers in this presentation will help you in weighing that risk, as you're very influential in decision-making as anesthesiologists in helping to, I guess, decide when elective surgeries should be scheduled. I think this can be very influential because the immediate risk, excess risk of death is something that we would have to contend with. And then there is, of course, the immediate risk of death, perhaps with the surgical condition, which needs to be weighed off against that. And in this particular presentation, it really is only the vaccines that we talked about that may be able to reduce the risk of the patients getting SARS-CoV-2 in the first place if they are scheduled for surgery. So lastly, I think that we need to think about updating our guidelines. So when this Surge Week study was published in Anesthesia a few weeks ago, the UK anesthesiologists got together and right away actually created an updated guideline on recommendations for return to timing of elective surgery post-infection. So I think that's very helpful for us. Other guidelines have not necessarily been updated yet with the newest data. So last time I looked, ASA, APSF still had our older cohort data from our initial 1128 patients. And so I think this needs to be updated, and our own local guidelines as well. So just lastly, just to leave off, so for the multidisciplinary rounds in May, I'm going to talk a lot more about the other clinical implications of SARS-CoV-2 diagnosis around the time of surgery and what we can do to mitigate that. But I just want to give kudos and I think credence to the benefit of doing large pragmatic studies like this. This really had to be done on a global basis in order to get enough patient power, sample size, and range of representation of settings and surgical type and risk strata and time post-diagnosis in order to be able to get answers like this. So I think we've moved into a new era where we really do need to be globally joined up to do studies at this level in order to come up with answers that are meaningful and clinically relevant. So with that, I will stop and would love to hear your questions, discussions, comments, etc. Thank you. So I'm just opening the chat here. Oh, I see some questions. So first one is, did you look at the type of surgery, i.e. lung surgery versus orthopedic, et cetera, et cetera? Yeah, so I think that I'm jumping into the middle of the questions here. So that was from Rick Multhaner. Thanks, Dr. Multhaner. So we have all of the data by type of surgery, and that is upcoming. So future publications will give the event rates by the different types of surgeries. So hang tight, because the group in Birmingham is working around the clock spectacular in order to come up with added information around that, because they know the sooner the better. I'm just moving up to the top of the questions. So I see another one here. Sorry. Great. So from Chris Hansboat, okay. Was there any stratification regarding patients who contribute to test positive? Sorry, was there any stratification regarding patients who continue to test positive for COVID with or without symptoms? Okay, this is a great question. I'm glad you asked it. We don't have that stratification available yet. So it's possible that might be able to be looked at post hoc, but at this point we weren't able to get to that granular data. So the question there was continuing to test positive while also being symptomatic. I'm truthfully not sure we'll able to get there because of the way that we collected the data in the cohort. Question from Mike. Was there any data about morbidity and mortality for general anesthesia versus regional versus sedation? Yes, so we collected that data. And I'm just hesitating because I just want to make sure that I'm not mixing up the final COVID surge, global surge week, the data points that we collected with the prior two studies that we did. So we did the first cohort, we collected general versus regional versus sedation data, and we reported that. And interestingly, in our first cohort data of 1128 patients, the risk of mortality did not differ by type of anesthesia. Okay, so the risk was all the same. In our second study, which we don't have all reported yet, which was the COVID surge cancer cohort, I'm not sure that we would be able to get that data from there. From the last, this very large surge week data, I believe we did collect that data in our anesthesia sheet. So we had a surgery sheet, anesthesia sheet. And if anyone who helped me collect data during that week, just remind me if I'm right about that. All of that to say, I think we have it, and I think we would be reporting it once we republish our big full data set in terms of mortality and all of the risk predictors. Question from Lee. Okay, due to the nature of an observational study, we have to be very careful regarding the interpretation of the results. You found the highest mortality among the elective surgery for cancer patients who are 70 and above. Did you adjust the severity of the surgery besides ASA? For example, patients with more severe conditions might be willing to take the risk for elective surgery during COVID-19. Thus, the mortality rate is higher in general. So I like this question. Okay, so this question is asking me whether or not we adjusted additionally for the severity of the surgery. And the short answer to that is we did. So our adjustment, our model, tried to adjust for and correct for anything else, any factors that might be able to explain the differences that we're seeing in terms of mortality. And yes, we had baseline ASA, but we also had degree or severity of surgery in there as well. Okay. And it's incredible. Again, if you take a look at our subgroup analyses and take a look at the type of surgery strata, you'll see that the absolute differences, the relative risk is quite similar in terms of the story, the pattern that's told, okay? Whereas the absolute differences are quite different between major and minor surgery. So that's all of the questions that I see in the chat. I'm not sure if anybody else has questions or comments, and or if you have access to your microphone to do so. I can't remember, Mark, if that was possible.
Yeah, they can turn their microphones on and ask a question if they have one.
Yeah. Yeah, I welcome questions, comments, anything else.
Janet, it's Praveen Batoi. That was a great talk. Thanks. Hope you're hearing me okay. You can just nod. Okay.
Thanks, Praveen.
So in these studies, or when we're talking about COVID in general, we always talk about the death rate in somebody who was diagnosed, who had a positive COVID test. But is there any way to figure out the deaths because of COVID? For example, the patient who didn't go to hospital with chest pain because they were worried, or the cancer patient, who waited a little longer, so the lump is a little bigger, the cancer has spread, or the young person who's lost their job and just feels completely distraught and then goes and commits suicide. So those are the numbers. I'm not sure if it's possible to capture them because they're hard to count. But certainly when you recommend vaccines, I'm not so sold on the fact that, yeah, we should, based on your numbers, it makes complete sense to recommend vaccines to cancer patients older having surgery. But in the bigger picture, I'm not so sure about that.
Yeah, so such a good question. And it's one of those conundrums whereby for patients who do not reach the table, right, if we're thinking about surgery, or who now are reaching the table later and have more advanced disease, to what degree is COVID directly or indirectly related or causing and contributing to excess mortality at a population level, both surgical related mortality and non-surgical related mortality? And that is such a great question. And there's a number of groups, including our one of our postdocs at the Medici Center, so Eunice Chan, is working with us. Dr. Eunice Chan is working with us as well to take a look at across populations. So the first population we looked at was the USA, and then we also took a look at the UK, so England and Wales. And because the numbers were available at a population level, and we took a look at now how much excess mortality is there at a population over and above what would have happened this year anyways, right? Because people die. I mean, we reach the end of our lives. So stratified by age, what is the excess mortality that is occurring at a population level? And we did find an excess mortality, about 2/3 of which had been attributed to COVID on death certificate, one way or another, whether direct or indirectly, and about 1/3 on average was not attributed to COVID in the excessive mortality above expected mortality. So I think that's something that is starting to play out and is absolutely of interest, should be especially of interest to those of us interested in surgical conditions and the direct and indirect impacts of COVID on surgical conditions, because even the impact of COVID directly on surgical patients, which is largely what we talked about today, excess risk of mortality and pulmonary complications, inherent in that is something that we need to fear now as the months go on more and more, and that's the increased acuity of the patient coming to the table, and whether or not the profile of the patients now has changed. And then second to that, what about the patients that just don't have the chance now because of the backlogs of elective surgical cancellations? And that's something now that we need to keep track of at a population level, country by country, in order to calculate that excess mortality and to what degree we're having population mortality rates over and above what was expected this year and next year and for decades to come, I think. I think that that was a great question, Pravin. I don't know if you had, if that was helpful or if that was what you were intending to
No,
get
that
at
was
there.
very helpful, and I'm glad that like the world is thinking about this, because it is an important thing. I think we have just been caught up in trying to prevent COVID without thinking sort of slightly broader than that. Because as you point out, there certainly are excess deaths, and we read about it in even in the newspapers now. So the effect of COVID is going to be much bigger than we ever expected it to be. Once we finally count, whenever this ends, who knows when that's going to be now. But a great talk, and I'm sad that it was only like a small number of people attended. Like, I know Mark's recording this, but this would be an important talk for basically everyone involved in surgical work at our hospitals. Like, you should have had hundreds of people at this talk, but hopefully, the message will be disseminated through, journals and things like that. But
Yeah,
thanks.
it's a busy time and a stressful time, isn't it, in the surgical setting? So, but yes, the recording is available. And also would just love to chat further with a smaller interested group as well about just changing our guidelines locally around this data, and also some of the emerging data that we have coming over the coming weeks. And so I think I see a new question here from Mohammed and Rudy. Okay, great. Mohammed says, bit off topic, do you have any data on transmission to healthcare workers, especially when it comes to patient vaccinated or not? Oh yeah, so that's a great question. It's an area that we have been working on outside of the global surge collaboration, um, and inside the global surge collaboration. So here's what we have. So we haven't reported yet the data that was collected for COVID surge. Okay, so that's still upcoming. But what we have done within Medici and in partnership with the World Health Organization previously, so this has been a long journey. We actually were working on Ebola virus disease and other viral epidemics and the impact on surgery prior to COVID-19. And that is a whole talk in itself. But interestingly, Ebola and Marburg virus increase the risk of perioperative mortality rates. And similar story in terms of magnitude of risk of increase compared to COVID-19. Again, it's uncanny just how similar that is. But more importantly, in that Ebola work, we had already set up a large global model to evaluate the excess risk of transmission to the healthcare workers in the context of Ebola, and then in the context of many other viral epidemics since then. And now in the recent year, we've done so or are still working on it for COVID-19. And so I hope we'll have time to discuss that at the multidisciplinary rounds in May, because there's a lot to unpack there. The issue of, so Mohammed, your question was around then, how could the vaccines also protect us as healthcare workers against transmission? And I think that the intuitive answer would be yes, probably, but we didn't evaluate that in our model. So that would be another added layer of benefits of vaccination, routine vaccination of elective surgical patients prior to their surgery. So that would just certainly add to those benefits. I think Rudy had a comment or a question. Oh, he's saying thanks. Thanks, Rudy. And then there might be one other. Nope, that's a previous question that we also talked about. Okay, actually, a new question came in from Dr. Cheng. So also at Ministry of Health, the Provincial Innovation Fund projects have prioritized to COVID-19 studies in all levels of risk and prevention and treatment, surgery, ICU, post-op patients, mental health, healthcare workers in Ontario. So more to come from Ontario from all the Innovation Fund projects through the IFPOC will profile these many Ontario studies on COVID. Yeah, so that's true. I mean, we're not the only ones obviously working in this space. So there are a number of other Ontario specific projects, but there's also a number of other studies ongoing globally. And, next month, I hope to be able to talk about some of that, just putting the data together across what exists. So COVID surge, global surge has, done a huge service by collecting data on 142,000 patients. But there are some dimensions that haven't been addressed by COVID surge, global surge, which need to be addressed, and which I think we'll have some fun talking about in the coming month.